I said, well, how can this be? Here's the answer I got. You know, you got to remember, a lot of these people come into the doctor's office and they get a quick and dirty. Oh, is that like a medical term? Is that in DSM-4 as a treatment protocol? A quick and dirty? They don't operate machinery, they don't complain, they don't read complicated texts, they're not working. Just get them in, get them out. Other people, you know, there's a lot of doctors don't want them in the waiting room. You know, they don't want to make other patients feel uncomfortable. And the list went on. So I'm just saying all this because for me, I couldn't believe it. I thought, you know, the previous, you know, Dr. Evans' presentation, we closed the institutions. You know, we opened in group homes. I know we had some people opposing group homes in the community I was living in at the time, and we had a rowdy session of neighbors opposing moving it. But I mean, I figured that was an isolated example. We closed the group. We're opening group homes, closed the institutions. We, you know, we had IDEA. You know, we had the ADA. Didn't we do all this? So to me, it was a shock. We went to the Yale University School of Public Health. We asked them to do a study, which we commissioned them to do. Give us a lit review. What's really going on here? Was this an exception? Was this a fluke? Did we just chance upon something wrong? What's going on? What does the literature say? So they came back and said to us, the honest truth is, we can give you a lit review, but the literature is lousy. The data is lousy. I said, look, I need whatever you got. So we commissioned this study, and we invited the Surgeon General of the United States to come up and look at our screening in the year 2001 in Alaska. And we invited then Senator Ted Stevens to have a hearing. Let's have some discussion. Let's see what we know. Let's present the Yale report. Let's have the Surgeon General come up and take a look. Let's see what's going on. And this is a picture in the lower left-hand corner there of Loretta Claiborne, the great self-advocate and Special Olympics athlete, speaking at that hearing. And by the way, I know I said I was going to go quickly and I'm taking too much time, but her closing of her remarks at that hearing. So can I tell a quick little story about the hearing? So Stevens gets up and he says, you know, this is a big crowded room of Special Olympics people and they're cheering and clapping. He says, you know, he has his gavel. The United States Senate is now in session and there's no applause allowed. There's no speaking. So please observe Senate protocol. So, you know, I get up and I give my little 5-minute speech and, you know, run back to my chair. Nobody says a word. And then my brother-in-law, Arnold, gets up and he does a little speech about what he's doing all over the world. He wasn't a politician at that time, and he goes back to his seat. And David Satcher, the Surgeon General, back to his seat. And then Loretta comes up and she's talking about her life. And she says, you know, at the end, she says, you know, Senator, last week I got a call from one of my friends who's in prison. He's a good guy, but he's doing time. And at the end of his call, he says, I got to go because I got to go see the dentist. He says, Senator, I can't see the dentist. He says, there's something wrong with the country. She says, there's something wrong with the country where a person in prison gets a better medical care than me. Thank you, Senator. And the whole place just exploded. Yeah, you want to just applaud. You just want to applaud even now. It's so much, I mean, just even me trying to channel her. Anyway, so we did this, and the Surgeon General met with parents, and we had the perfect combination. For those of you interested in activism, we had the perfect combination. So we had a dedicated public servant in David Satcher. We had the good data, the best data available in the Yale report, and then we put them together in a room with 14 parents who were furious about the care and treatment their children were getting. And Satcher said, I get it. Blinders are off. I'm going to do the first ever Surgeon General's report on the health status of people with intellectual disabilities. And that report there to your right is the result of that. So in the meantime, again, most of you know this, so I won't spend a lot of time on that. We, on our own, launched the Healthy Athletes program more formally. It now includes opening eyes, healthy hearing, health promotion, the MedFest program, Special Smiles, of course, Fun Fitness, and Fun Feet. We are trying to do nutrition, sun safety, tobacco cessation, strength, flexibility, fitness, all these kinds of different things throughout the Healthy Athletes universe of programs and trainings. Here's where we are. Just a few months ago, we don't have the exact date, we've done 1 million health screenings around the world. 90,000 healthcare professionals have come into these screenings and been trained, most of them for the first time in the care and treatment of people with intellectual disabilities, most of them for the first time getting hands-on exposure, relationship-type exposure, the capacity to see, talk, listen to, and build friendships with. We've distributed almost 80,000 pairs of glasses for people who needed glasses who didn't have them. Most recently, even in Athens, 3 weeks ago, I should have them here, a pair of glasses where the person, 20, I believe 3 years old, never seen an eye doctor, and field of vision was, I think, 19 inches. So this is a person, 19 inches of sight, had walked, of course, like this her whole life, because she can't see. And she got her first pair of glasses 3 weeks ago. That's just one of hundreds of stories, thousands of stories like that where people have never had the care. And we have this database, which is so important. I'm going to ask Gloria to talk about this before I finish, of about 120,000 health records, 120,000 screenings that we can now access. That database will continue to grow. How we use it, how we continue to build it, is part of the challenge of today. So what do we get from this? Well, we get wonderful stories. Here's a group of people from the University of El Salvador. Their dental clinic, they were trained at Healthy Athletes and now open their dental clinic free of charge to people with intellectual disabilities. A connection between someone trained, someone exposed, and the delivery of care in the community. That's the kind of referral and networking resource we hope to create. Here's a good example of a blank slide. Here's a good example from Indiana of one of our athletes, Jeremy Hausman, who's in Fulton County, Indiana. Been screened, was told he had overweight issues, and committed to walking 12,000 miles in 1 year in order to lose weight and raise money. They call it their walk to Athens. They're going to try to go to the World Games in Athens, Greece next summer. But in the meantime, he's already lost 4 inches on his waist and is creating a club there for people with intellectual disabilities to promote year-round fitness, weight loss, and cardiovascular health. So these kinds of referral and behavior change challenges we hope are very important. Here's a school in South Africa where a bunch of Healthy Athletes volunteers, after training, went out to the school, recognized significant nutrition problems, worked with the residents at that school to plant an organic garden. So these residents, these students in effect, are now growing their own vegetables and working on a series of other issues around HIV, alcohol cessation, tobacco remediation. But again, trained healthcare practitioners moving into the community, empowered with the knowledge to realize there are health disparities and committed to finding creative solutions to those disparities at a community setting. Our curricula in medicine, in psychiatry, in dentistry, and vision, done in support with the American Academy of Developmental Medicine and Dentistry. 4 curricula, DVD-enabled, web-enabled curricula that just give physicians and healthcare practitioners quick exposure to the issues facing our population in these areas. So these are sort of the avant-garde, if you will, or the frontal assault on medical training and continuing medical education. They're certainly not adequate for a revision of the medical curriculum, but they're at least beginning spots. They're at least ways in which we start to infiltrate, we hope, the medical training. Here's a photograph of an athlete, a person with an intellectual disability, seen, I believe it was last year, in the United States. This is in Kentucky. His name is James. Part of the Special Olympics movement. But also through a number of resources, accessing, finding his way to a dedicated dentist and a dentist with specialized training in developmental disability. At 42 years old, this is how he presented in the dentist's office. This is not 1950. This is not a picture taken at Beatrice State School. This is a picture taken, contemporary picture taken, of an American adult with full access to the rights and privileges of the ADA, with full access to the rights and privileges of the most wealthy nation on earth. This is the quality of the care he presented. Now, the good news is that when you have trained people, this is what they can produce. No, this is not Jenny Craig. This is not Dr. Besser's here from ABC, but we didn't have anybody in the studio working on this. This is a dentist with a camera in a clinic. It's not really, in a way, that complicated, but in another way, of course, it is. The research work we're trying to do also, I think, is relevant to the challenge. Over 120 studies, and I won't go into detail, obviously, on these because we don't have time, but the point is that Special Olympics is a vehicle for embarking on more creative research that will drive attention to this issue, that will help us understand the parameters of change, help us inform the ways in which we can shift attitudes, because I believe, for one, that the attitudes are central to this. And we've got healthcare reform. I mean, the good news here is that the healthcare reform legislation, I believe, I hope I'm nonpartisan in saying this, does result in significant changes for people with intellectual disabilities. The elimination of pre-existing condition limitations, language eliminating or setting goals of eliminating health disparities is very important to our population. We'll see over time how this all plays out, and I know there are many, many differences of opinion as to whether this legislation was a good idea or not, but at least we see some progress in the issues facing our population. And of course, we have our own vision of an act dedicated to the honor of my mother that would allow us to continue to expand healthy athletes and education work at the community level, driven by volunteers, to continue to create the community networks necessary to remediate the problems we see. We also have great news. I don't know if any of you have met Arya Neiman, or many of you know Chester Finn, I'm guessing. First time people with intellectual disabilities, person on an autism spectrum and a person with a developmental disability is appointed to the National Council on Disabilities. And again, just a reminder, we talk disability, but disability, as we all know in this room, is physical disability and intellectual disability. Not by the numbers, but by the influence. And so for our population to be included on these councils, to be heard, to be listened to be thought to be powerful enough and valuable enough to be integrated is good news. Are we done? No, we're not done. The data is, if the question of this presentation is, have we closed the gap? The answer is very easy. You can look at it in statistics like these, or you can look at it in the story of Jessica that I heard last night. My guess is Jessica has several of these issues. This does not include psychiatric disorders. Some of the greatest discrimination we saw in the Yale Lit Review by providers was amongst mental health providers. Some of the greatest, listen to that, the occurrence of dual diagnosis, the occurrence of psychiatric problems together with intellectual disability is disproportionately high. The care and treatment amongst psychiatric providers and mental health providers for people with intellectual disabilities is one of the worst subspecialties within the adult care system. One of the worst. You think if someone's interested in mental health, well, they'd be very interested in our population. They'd be very open to it. It's the exact opposite. So to the extent where this country's looking for mental health parity, looking for depression and anxiety disorders and personality disorders and conduct disorders to be treated as significant medical conditions with full access to medical care, to the extent that's the vision, our population is way behind. We don't have the data on it, but we see it all the time. So that's a whole nother challenge that's not captured in this data. Obesity. People say, well, what's the intervention? Dr. Best and I were talking last night. What's the intervention that works for obesity? No proven interventions that work. I'm thinking to myself, you're right, no proven interventions that work. And then all of a sudden it hits me. Well, there is one. Running, exercise, physical activity. How do you get people to do it? Another challenge, but it's pretty clear. It's pretty clear that with significant physical activity, regular exercise, sustained commitment to sports training, physical activity, and fitness, you lose weight. So it may not be the most fancy intervention. It may not warrant the creation of a press release. It may not deserve its own new website, but get moving. It does work.